So a warm welcome to our seminar this evening. We've got beautiful sunshine and I know it's absolutely gorgeous outside. So we do appreciate everybody joining us, but we know the topic of medication and ADHD is always something that's very close to the hearts of our families with children with ADHD. So I'm going to now turn to Professor Hill and really warmly welcome him to our seminar this evening. Prof. Hill has been a long-term supporter of ADHD Richmond and Kingston, and we are really very fortunate that he's agreed to talk. He's also been practicing for over 30 years. I'm sure he'll correct me and give me a more precise number, but he's one of the most experienced pediatricians in the country, and really an expert on the subject of ADHD. I was fortunate enough when my son was much younger and still on medication to be under the care of Prof. Hill. And he really works very well with families and incredibly supportive. So we're really fortunate. So with that, Peter, I'm going to hand the floor to you. Thank you.
Well, thank you. That is kind and generous. Thank you for comments. This is, you'll see that this is an unsubtle plug for a very recently written book that took me 2 or 3 years to put together. As I was saying earlier, it's not going to make me any money. I mean, that's perfectly clear. But it's an expression of something that the pediatrician David Hall and I think we started way back in the 1970s, when we turned the Child Development Clinic at St. George's into a clinic for parents. And we made that quite explicit, that we would talk with parents, we would write to parents, and the whole enterprise was parent-centered. And that, at that time, was quite radical, because at that time, usually, pediatricians and child psychiatrists wrote back to the referrer to say, I've seen your referral, the diagnosis is, the treatment's going to be, and that's it. And we tried to shift that into a more explanatory clinic. And that has been the attitude that I've tried to pursue subsequently. And that is what this book is about. It's about how you can, as a parent, talk on level terms with a prescriber. The prescriber may be a pediatrician, prescriber may be a psychiatrist. I'm talking about children and adolescents. But increasingly, the prescriber may be a pharmacist or a prescribing nurse. So although I'm a doctor and I write from a doctor's perspective, there is a sharing of orientation and interest, I think, with other professions, increasingly the nurses, and I'm pleased to say the pharmacists, taking the view that we need to talk with parents, but not exclusively with parents. And at some stage, I'm going to point out that it's very necessary to listen to the children with the diagnosis. So this is a new effort. This came out in only a matter of weeks ago, late April. And I think it's sort of number 258,000 on the Amazon seller list. It's not going to be a bestseller, but I do think it's important. So this is the Parents' Guide. We had a lot of debate about the title because I wanted to call it other things, but ultimately we decided it's the Parents' Guide to ADHD medicines. And I'm using the word medicines intentionally. Now, let's use the keyboard. Can't use the keyboard. Let's use. I'm stuck on moving my slides around. This isn't good, is it? Here we are. Okie doke. So I hope that this book deals with something to do with the language of medicine. So one of the things that's very obvious, talking to people who've done surveys of ADHD clinics, is that the language gets in the way. The prescribers and the parents, and indeed the children, the young people, children, teenagers, don't share the language, and muddles arise. So I want to talk a bit about that. I want to talk about just how we know that ADHD medicines work. I don't want to spend too much time on precisely how they work. It's how we know they work, because that seems to me a slightly more important issue. Obviously, everyone is concerned about side effects, and that's probably the commonest question I'm asked if I say, well, I think we ought to think about medicines. And what about this medicine? And sure as Wimbledon, the ball comes back, what are the side effects? And I want to say something about that. And I want to say something about how doctors, and I've said doctors because doctors initiate medicines. Nurses and pharmacists may continue, but it's doctors who initiate the medicine. So the way they choose medicines becomes really very important. I'll comment about some of the less used medicines, and I'll say something about dietary supplements. I know that dietary supplements are not a medicine, but in real life terms, they're often viewed as such. And I want to say, if I can, how I think this is a sort of moral message, how doctors should be encouraged to think about medical treatment. There's a lot of other stuff, but I've picked up those 7 topics because from my perspective, they're important, but there's other stuff. Now, having said that language is an issue, one of the most obvious problems is what you call drugs. I've used the word drugs here, though generally I prefer the name medicines, but you'll see why I'm using drugs, which is the technical term, which unfortunately overlaps with all sorts of illicit recreational substances, as we know. But the names become important. And there are 3 levels of names. I mean, there is for any medicine, for any drug, there's a chemical name. And there is all this stuff up there, piperidine, acetic acid, alpha-phenol, methyl ester. Yeah, fine. That's methylphenidate, of which the commonest brand name is Ritalin, though not the commonest used preparation. And nobody uses that. So we don't have to talk, although we're talking chemistry here, we don't have to talk chemical formulae, thank goodness. The scientific generic name becomes important. And this word generic gives rise to quite a bit of misunderstanding, so I'll come back to that. But methylphenidate is the first medicine to be used in most countries, not necessarily the States where it's an even choice between dexamphetamine, or amphetamine actually, and methylphenidate. But in this country, methylphenidate is the recommended first choice if you're going to use medicines for ADHD. But what then happens is there we go, it's insensitive. Okay, so everyone knows the brand Ritalin. It's very important, it was very important for me to learn and realize that when you're talking to schools, there's no point talking about anything in terms of medicines unless it's Ritalin. In the educational world, there's only one treatment for ADHD, and that's called Ritalin. Ritalin is interesting stuff. I think people have heard me mention that it was initially named after Rita, the inventor's wife, because it helped her stamina during her games of tennis. It became Ritalin in her honor. And it was initially marketed for energizing bored housewives in the Midwest of the United States. And that was quite explicit. Then it became slightly rationalized, and you'll see on that label that it's regarded here as an antidepressive. I'm not sure whether an antidepressive is really quite the same as an antidepressant, but it makes the point, as far as I'm concerned, that a medicine may be developed for one purpose and then discover that it's useful for another. So Ritalin was developed as a tonic, as it were, for dispirited, bored women lacking in energy, and it was specifically women. There's a long history about the marketing of Ritalin, which is interesting to some people like me, but I won't go into it in great detail. Well, I won't go into it at all, actually, other than make that point. So there is your brand, and that is, the brand name is different from the generic name, and the brand name then gets you into familiar territory. So you have methylphenidate as the generic scientific official term that you may see on a prescription form, and then there are a whole host of brand names from different manufacturers: Ritalin, Medicanet, Tranquilin, Delmasar, you name it. Whereas for the other ADHD medicines, it's rather more straightforward. For dexamphetamine, it's either prescribed on a prescription as dexamphetamine or as Amphexxa. And the Amphexxa brand is a little different from ordinary generic dexamphetamine because you can break the tablet very easily. So it finds favor in some quarters and it finds favor in other quarters because it's a bit cheaper than mainstream dexamphetamine. But I'm not here to plug Amphexxa. I can't even remember who makes it. Lisdexamphetamine will be more familiar, I think, to some of you as Elvance. And Strattera is usually written up as atomoxetine, and Intuniv as prolonged release, extended release guanfacine. It's extended release in the States, prolonged release in Europe and the UK. So this distinction between brand names and generic names causes confusion. And I'll mention later why it's actually important to suss this difference. The NHS wants doctors to use generic language. It wants them to write methylphenidate or atomoxetine or lisdexamphetamine because the generic medicines are often, not always, often cheaper, because a manufacturer may invent a medicine which works. I'll come back to that if I can. But after about 15 years, what the lawyers call patent, but I was brought up to say patent. I've spoken to too many lawyers in the last few years. The patent runs out. So generic alternatives appear. Ritalin was around for a very long time, more than 15 years. And then people cottoned onto the fact that you could actually make methylphenidate and call it something else. There was nothing to stop you. So in historical terms, you had, well, we currently have Tranquilin, we have Medicanet, yeah, let's leave it at that. Generic alternatives appear. This is probably most evident in what are known as the Oros formulations of methylphenidate, which started out as Concerta XL, but when the patent on Concerta XL ran out, then everybody piled in with initially Mataride XL and then Zenidate and so on and so forth. So you have all these branded items that contain methylphenidate, but are cheaper, quite a lot cheaper, about a quarter or a third of the price of Concerta XL. It depends how you buy it. I've said half the price because across the board, that's more like it. The Concerta versus the generic alternatives to Concerta is actually quite a dramatic difference. Now, if you are a manufacturer of a substitute, let's say the patent on Concerta XL has run out, so you have a good look at the Concerta XL tablet and you think, I can make this and I can make it more cheaply than the original manufacturer. So let's have a go at that. And you make it and you think, yeah, this is pretty good. And you run some trials on it to show that it's pretty good. And you then take it to a licensing authority, the MHRA, for example, and you say, can I now release this to the market? Can I sell it to the NHS? Can I sell it privately through pharmacies and so And the MHRA will say, well, we have to establish whether it is bioequivalent. In other words, more or less the same. And if it is bioequivalent, then you, the manufacturer, you can have a marketing authorization, a license to get it out there. And this is not quite as simple as it seems. So the licensing authority, I mentioned the MHRA because that's what it is in this country, the European Medicines Agency, the FDA, the Food and Drugs Administration in the States, they use this term bioequivalence. So a new generic drug replacing an original brand need only actually produce 80% of the blood level, let us say, of methylphenidate produced by the original. So it's not exact equivalence. And over again, I hear parents who've gone into a chemist or gone into a hospital pharmacy, and they've been given something that they're not used to. They've been given a preparation, usually of a sustained release methylphenidate, like let us say Concerta XL, for example. And now they've got something called, well, let's say Materite. And they say, well, after a few days, this isn't quite so good. Actually, Materite's okay. But they're quite right. They come back and they say, look, this isn't quite as good. And the pharmacist over the counter will say it's exactly the same. The prescribing doctor will say, no, it's the same stuff. It's exactly the same. It isn't. It's bioequivalent. But to be bioequivalent, you only have to produce 80% of the blood level produced by the original brand. And actually, there's a 5%, you're allowed 5% error, so 2.5% either way, maybe as little as 77.5%. So the generics are not necessarily exactly the same. They may be perfectly good medicines, but you can't match doses. And I think this is where a great deal of the trouble arises, that the parents quite rightly say, this stuff isn't as good as the original. And instead of getting into an argument about, yeah, but you know, that's all psychological or something unreal, it's exactly the same. What the prescriber should be doing is adjusting the dose. But that doesn't always happen. And I talk to, I mean, one of the things I used to do was talk to pharmacists, trained pharmacists in this area. And I know that across medicine, bioequivalence is not understood. But it's all there. You can look at the EMA website or the FDA website. It's actually in the MHRA website. And you will find a paragraph there which explains this, that you only have to match a blood level to... I've got an interesting question from, which I don't know whether you can see, but it's actually stopping me. And I'll come back to how.
Peter, what I suggest we do is we'll deal with the questions at the end. So right. Ignore the chat bar for the moment. We've encouraged people to put their questions in, but just keep going.
And don't be distracted. It came on my screen and obliterated the forward button. That's why I was. So associated with bioequivalence is this idea of a license. And I know this causes distress to some families because the prescriber may say, well, I'm not going to prescribe that, it's off license. Now, I also heard doctors say, I'm not allowed to, because it hasn't got a license, so I'm not allowed to. I've heard a professor of psychiatry say that to me not so very long ago. I'm not allowed to prescribe this. It hasn't got a license. That's rubbish. A license has nothing to do with prescribing. A license is a marketing authorization, which is given to a manufacturer. So you might be a big, or indeed a small manufacturer of medicines, and you go to the MHRA, one of these organizations, the FDA and the EMA, and say, can I market my medicine? And they say, yeah, have you shown bioequivalence? And you say, yeah. We've done all the trials, we've done the blood levels, we've done all that. Is it okay? Is it safe? Yeah, we've done all that. It's perfectly good. Can you make it consistently? Yes, we can make it consistently. You'll rather gather I've worked with these bodies, so I know the jargon. And they then say, okay, you can have a marketing authorization. The FDA call it an approval. The EMA, the European Medicines Agency, called it a marketing authorization, because that's what it is. The Brits call it a license, which is the wrong term. It's a license for a manufacturer to release their medicine to the market. And when they get their license, it's very restrictive. It says what the dose is going to be, and what it's for, what treatment is it for, what's it meant to do, and for which age group, which is really quite important. Because you may have a medicine that has a license for adults, but not for children, because the original trials were done on adults, or vice versa. For a long time, we've struggled with the treatment of adult ADHD with medicines, because the licenses were given for children, explicitly for children. So the license is very much about companies, it's not about prescribers. Most licenses are granted on the basis of scientific trials in adults, because it's so difficult to do trials with children because of the ethics of getting consent. Who's going to give the consent, and so forth. That's not such a big deal in ADHD, but it's a big deal, for example, in the treatment of depression. So it's nothing to do with doctors. But on the other hand, managers are very keen on licensed medicines because they know that so long as somebody sticks to the license, it's pretty safe. That is the argument. You know, if you prescribe off license, you're doing something on which there's no hard data. That's actually not true. Plenty of hard data about medicines off license if you compare trials or publications in different countries. But the managers are very keen to stick with licensed medicines. And I've seen that over and over again, that a particular hospital or some local NHS authority will say, we stick to NICE guidelines or something like that. They're very keen on NICE guidelines. And we will only sanction licensed products. That is, I mean, okay, you can do that. But if you do that, you'll end up not treating an awful lot of people. As it happens, nearly always, doctors at any rate can prescribe off-label. You don't have to stick to the license. You may have to argue the case with somebody up the line somewhere, but you are actually entitled to do it. So the statement by the psychiatrist that I mentioned saying I'm not allowed to is not true. And well, I'll loop back to the topic, but please don't get bullied by people who say that it's off license and therefore dangerous. The power that organizes all this is the local formulary. The local formulary is a list of which medicines can be prescribed within the NHS locally. And it's usually organized along something like a traffic light system. There are medicines that are regarded as red, which should only be prescribed by consultants. There are those who are amber, where a GP can prescribe so long as they link in with a consultant, probably by having a shared care protocol, for example. But the formulary is a list of which medicines can easily be prescribed. There's nearly always, if you get hold of the formulary, which isn't always easy, but some people publish it online, if you get hold of it, there's nearly always an escape clause somewhere in there to say, in exceptional cases or some such phrase, doctors may prescribe without reference to this formulary, or that's nearly always there. I remember the last time I spoke to this group, there was a very distressed person in the audience who'd been to her GP, and the GP had said, I'm just not allowed to prescribe it. My local formulary won't allow it. I got hold of the local formulary, the South West London St George's formulary. And actually, there was a perfectly straightforward clause in there to say, yes, you can, but don't do it normally, sort of paragraph. The local formulas are very much driven by cost. For example, when guanfacine, when Intunif came in, I know that several paediatricians and psychiatrists went to their local formularies and said, we want to include this. We want to have this approved by you guys and get it all straightforward. And I had a report back from one paediatrician who'd been to the local formulary, and the only question he was asked is how much did it cost? And when that was mentioned, they said, well, no, you know, that's going to be red, consultants only. And that was the attitude taken. And I think that's not, well, it isn't the only story I've heard that's essentially the same, that money drives approval. Whether or not it adds to ordinary treatment isn't considered. It's just all about money. And I mentioned the traffic light system. So I'm talking about local formularies and licenses and bioequivalence as issues which I think parents need to know about. It's a bit technical, but actually the prescribers don't always know their way through this. I'd like to say something about how we know that medicines work. This is the source of an enormous amount of academic debate. How do we actually know that this stuff works? You might have seen in the newspapers that there's a new ADHD medication released in the States just a very few weeks ago, after the book came out actually, which is viloxazine. There's a lot of stuff about the trial they carried out to show that viloxazine worked. The trial does show that it is effective, and it also looks for safety. You know, how many side effects? I must say, I don't think we should be too enthusiastic about viloxazine. It's actually a medicine that's been around for donkey's years. It was an antidepressant in the 1970s, and I can remember using it then in that way. But it ran out of market, it didn't sell. So 19 years ago, it was taken off the market, but they found a new use for it. But let's not get too enthusiastic about it just at the moment, though it will have its place. But there's a great deal in the publicity about that, about the trial they carried out. Many hundreds of children, 6 to 18-year-olds, to find out whether it was effective. And the use, therefore, of a scientific trial is to give some of the children the active medicine, let's say viloxazine, and the other half will have something that looks very much like viloxazine, but actually has no active constituents at all. So you put it up against a placebo. You put the active medicine up against a placebo, and you have an agreed way of rating improvement, and you have an agreed way of looking at side effects, which is quite an article in its own way. The way in which side effects are looked at is really quite it's complicated, and it's big, and it magnifies the effects of side effects. So we use scientific trials to find out whether things work and what the side effect range is. That's what safety means. Safety doesn't mean, is it going to kill people? Safety means what adverse effects are going to happen. But the problem with scientific trials is there's only one medicine in the trial, nearly always. It's just one medicine, because these trials are usually run by manufacturers demonstrating that their new medicine is good news and works. So the difficulty with the reliance on scientific trials that, for example, NICE shows, is it's only one medicine at a time. The other problem is that you're looking at hundreds, in this case, 500 or 600 children taking this medicine. Now, you can show an effect for the group as a whole, but one of the first things I was taught in medical statistics is you do group studies to rule out individual variation, because individual variation is in some ways a nuisance if you're just trying to find out whether something's worked. But that doesn't mean that there aren't individuals within that group where it works better and those where it works less well. Those where it have one particular pattern of side effects and those where there's another. So the group study principle, which is worshipped generally in the science of evaluating medicines, has its difficulties. And the other, of course, is age limits. And I mentioned the problem about trials in children where you can't easily get the ethics right. You know, if it's the child taking the medicine, they ought to be able to decide whether they want to join or not. At what age do they do that? And you know, one can discuss that, and it should be discussed. The adverse effects that I mentioned are the side effects more commonly known. There are always going to be side effects. I suppose, I mean, the more you find out about medicines, the more you realize that medicines will do several things at once. So they may, for example, treat ADHD, stimulants will treat ADHD, but stimulants will also improve handwriting in quite a number of children with rubbish handwriting. Now that is a side effect. It's a side effect that may actually be very useful, but it is a side effect. In a way, the whole use of stimulant medication for ADHD is using a side effect, because these medicines were not originally designed to treat ADHD. They were designed to give people a tonic or a boost, whether that was amphetamine at the close of the 19th century, or, as you've seen, Ritalin and Rita's tennis more recently. So you find an effect that works, and then that may actually be a side effect of the original purpose of the medication. Remember the word antidepressive on that Ritalin bottle. So there are always going to be side effects. They will vary with the type of medicine. It may be, for example, the side effect is just because you're giving too much of them, too much of the medicine. For example, delayed, I'm talking jargon, but just generally sort of slowing up or inhibiting or socially sedating children is a well-recognized effect of too much stimulant. The dose is too high. There may be nothing to do with dose. It may be that somebody is sensitive or allergic to it. I've just come from a discussion about a patient, not one of mine, who was given a particular medicine and has developed mild inflammation of their pancreas. Now, that is a sensitivity reaction. I mean, it's very rare and it's very interesting. And I don't know why they asked me, but they thought I might know. And I said, yeah, you know, I know it can occur, but I've never actually seen it. But that's a sensitivity. It's not to do with dose. It may be that there's a direct effect of the medicine, not just on ADHD at an ordinary dose level, and not a sensitivity, but it will put, for example, heart rate up, as methylphenidate will. It usually puts heart rate up a few beats per minute. It's not terribly important, but it's a direct effect of the medicine. Or you may have a side effect where nobody knows why. So that a fair number of children who take methylphenidate or dexamphetamine get stomachache, and we don't know why. We don't really know how to treat it because it's a puzzle, and it's not important enough for research bodies to throw money at to find out what it's all about, unfortunately. So side effects are there, but they're not automatic. Plenty of children I see, I mean, don't have side effects as long as I keep the dose right. If they're not allergic, if their heart rate only rises 2 beats per minute, who cares? If they don't get abdominal pain, but they get a headache, well, that's awful. I don't want people to have a headache. But you actually treat the headache, usually quite straightforwardly with paracetamol. And the side effects may only last a short time. When you start somebody on medicine, you may pick up side effects, but if you plug on for 2 to 3 weeks, they very commonly subside. So they're temporary, or they may be short-term, like, for example, the effect on weight that you can see with atomoxetine, with Strattera. That is evident in the first 15 months or so, but it then melts away. Or there may be long-term effects. They're not many, and most of the long-term effects of stimulants are positive rather than negative. But I mean, everybody gets spooked about reduction in adult height for children who've been on stimulants. Actually, that's extremely unusual, I reckon. It's been seriously overhyped, and I have a lot to say about that if tempted. I'm pacing myself and realizing that I'm going more slowly than I predicted. This business about how doctors, who are the people who initiate ADHD medicines, how do they choose which one to use? Well, one answer is this protocol. This is the NICE protocol, which says, you start with methylphenidate in one form or another. Could be immediate release, could be a sustained release, and there could be a long sustained release or a medium one. But let's start with methylphenidate, and you get the dose up to a working level. But if after 6 weeks that really isn't producing the result you want, then you should switch to nearly always lisdexamfetamine, 12 ounce. And there's a perfectly sensible reason for that, that 25% of children who will respond to stimulant medication will respond to dexamphetamine, lisdexamfetamine, rather than methylphenidate. But we don't use lisdex, my slang, well, commonly used slang, don't use lisdex straight off because it has a slightly higher rate of side effects. If neither of those work, NICE says you then go to a non-stimulant and you choose between atomoxetine, that's Strattera, or guanfacine, that's Intuniv. So there is I'm trying to stop myself getting into a rant about this sort of thinking, but there is a protocol. There's a decision tree, if you like, an algorithm effectively about how you should work it. That's one way of doing it. The problem with that is that there's no guidance on combining medicines. In the States, there is a FDA approval, a license, if you like, to combine a stimulant plus Intuniv. And that is a very popular combination because all the side effects of Intuniv are counteracted by stimulants and vice versa. And you get the 24 action of guanfacine to complement the briefer action of the stimulant. So that's very popular in the States, and the studies show that it's safe, but there's no UK guidance. Nobody is putting pressure on NICE, and NICE wouldn't know how to respond because NICE is absolutely dependent on clinical trials. And although there have been clinical trials on the combination of stimulants plus guanfacine, they've been done on American children. And American ADHD is not the same as European ADHD. American ADHD is common and mild, and I can explain what I mean by that if you like. But the European authorities like the MHRA or the EMA don't like just accepting American data because the American kids have much milder ADHD. So what the Europeans want to know is, does this stuff work on real Germans, real Danes, real Irish, real Brits? And the answer is, well, we don't know because nobody's done the studies. There's no UK guidance on combining medicines, let us say for sleep problems associated with ADHD. There's a bit of muttering about melatonin in NICE, but there's no strong guidance. There's no strong guidance about the use of low-dose antipsychotics like aripiprazole or risperidone for aggressive behaviors in the home. Plenty of clinicians will use them, but there's no official guidance rather than think hard before you do it. And there's no guidance on how to add SSRIs, the sertralins or the fluoxetines. I used to say Prozac, but Prozac isn't available any longer. It's all fluoxetine. And that's important because actually adding SSRIs for anxiety in a child with ADHD can go wrong. So it's bad that there isn't central guidance. It was one of the things actually that got me writing bits of the book, just thinking somebody ought to say something about what makes sense, but that's my arrogance showing through, as usual. So protocol, they will also choose ADHD medicines according to whether they're available. Part of the availability is what does the local formulary say? It's that sort of availability. What am I allowed to use? Or sometimes, what's around? If you're consistently prescribing ADHD medicines, you get to know that, for example, some manufacturers run out of the 20 milligram dose of Lisdex, for example. That happened earlier this year, end of last year. But probably the main reason why doctors choose one medicine rather than another, apart from protocol, is whether they're used to it. I have frequent discussions with GPs who say, yeah, I hear what you're saying. This stuff ought to work, but I've never prescribed it. I don't know anything about it. I'm not happy to write a prescription because I'm not familiar with it. And you hear the same with locums. Locum doctors, locum specialists, locum consultants are very widely used in the NHS for all sorts of good and bad reasons. And locums are worked hard. That's one of the reasons why the NHS like locums. They can flog them to death and give them enormous clinics, and they will hoe through them loyally, but they won't change anything. A locum won't change. They'll just echo the previous prescription. They won't innovate. That's not really, in a way, what they're there to do, but it's a shame for the families. So you get, okay, I'm now a locum. I've got to see this family and this child. Last time they were seen 12 months ago, this is what happens, how things have been reasonable, but we don't, yeah, okay, well, let's just carry on with that. And that is quite a curse. And when a new medicine is introduced in the UK is much, much slower to pick up the use of new ADHD medicines. And I think it's clear to me, having been on several working parties about this, that it is actually that people stick with what they know, and the locums stick with what the clinic's familiar with, by the way. Coming back to my book, there are all sorts of other medicines that are available but less used. They're not on the NICE protocols, for example, but they are effective and they can be used, and we mustn't forget them. Clonidine is really like a rather more sedative version of Intuniv, but clonidine will sometimes work where Intuniv doesn't. They're very similar pharmacologically. And many years ago, this is what paediatricians would automatically use for the under sixes, where they didn't feel able to use stimulants because of licenses, etc., etc., etc. And clonidine was quite widely used, less widely used now, but it's useful stuff. Modafinil is quite widely used, of course, by undergraduate students as a study drug. It's not very good as a study drug, but it does keep them awake all night, so they feel it's giving them an opportunity to do some so-called revision or finish an essay or so forth. It will work in ADHD. It is there. The evidence for its effectiveness is there. But in the initial trial, one child developed a really, really nasty skin reaction. So it has been unpopular. That doesn't seem to apply to adults, which is why the undergraduates get away with it. But modafinil is there to be thought about. For years, tricyclic antidepressants, the imipramines, the nortriptylins, the amitriptylins, were used as treatments for ADHD, and they vary. Some of them are better than others. But nortriptylin has got quite a good track record. But now, of course, we don't bother. We use atomoxetine, Strattera instead. But they are there, and there are other antidepressants. But I've just been muttering about viloxazine. There are other medicines which do need to be thought about and remembered because they continue to exist and they have their uses. I've written a fair amount about supplements. The science is poor and therefore often conflicting. I think, well, the conclusion I came to after reading and discussing with people who do know is that by and large, supplementing with fish oil in this country is a waste of time. There are parts of the United States where it is actually valuable because they don't eat fish. But there's enough fish around for most people to get sufficient fish oils. And the evidence for across the board giving people fish oil for ADHD in this country is weak and is not really there, actually, in scientific terms. The effectiveness of zinc is, in many ways, very interesting. I have a colleague in the American Midwest who has done quite a bit of work on zinc supplements, and he has shown quite helpfully that if you deploy zinc very carefully, it's easy to overdose on zinc, but if you use one of the zinc salts, I think he actually in his study used zinc sulfate, you can actually reduce the dose of stimulant medication. And I mean, he puts that up just as, yeah, you can do this. Whether that's a good thing or whether it's worth the bother is a different argument. In Paris, iron supplements will treat ADHD. I can't make them work in London. And I've talked to the Parisian centre about why I can't. And they just say, well, your iron isn't as good as our iron, basically. But it is there. And the evidence, certainly from a very respectable centre in Paris, is that they were able to treat some children with ADHD with ordinary iron supplements. So that actually is quite interesting. Carnitine was for some years, if I go back 20 years, when we didn't have sufficient range of ADHD medicines, carnitine would sometimes work. It was pretty feeble, but again, there's just a little bit of evidence that it might. And there's a little bit of logic that says citicoline might, but the effects are so small that I think frankly, I don't think they're worth getting into. And the evidence is in such a mess with very small studies and contradictory results. So I'm trying to move the slide on and can't because I've got a, oh, great, there we go. The last issues really are, what can we say to doctors one way or another? How should doctors think about medical treatment? This is a moral position in some senses, but not all. I mean, there's perfectly good evidence that medical treatments are better if you put them in parallel with psychological treatments, whether those be educationally based or in older teenagers, whether they should be CBT based. But medical treatment shouldn't just be doling out pills. It should be part of a broader frame. Now, that statement has been around for so long, it's hardly worth saying it, but actually it hardly ever happens because the investment in psychological services for ADHD has been so low across the board. I think the other bits to say about how doctors should think is probably now much more about relieving impairment than reducing symptoms. This is quite an important shift by NICE, who 3 years ago said, actually, we must stop just counting up symptoms and say, look, this child is scoring 48 on the ADHD rating scale. We ought to try and get that down to 17. And I can remember being in conferences where this was the focus of concern. We ought to get these symptom counts down. But NICE is now saying, well, hang about. That's not the best way of thinking about things. The best way of thinking about things is to relieve impairment, to reduce the problems that the medicines are causing the young person. And I think the third point I want to flag up is that the medicine you choose, the medicine you use, that is going to depend on the context. There's been a lot of soul searching about should we increase the dose of stimulant medication when people come up to exams, GCSEs when those existed, and A-levels and so on. And there actually is quite a bit of information about that. But the short thing to say is, yes, you should, that the demand increases and therefore the impairment increases. And you should treat the impairment according to the context. So I think, once again, one shouldn't be rigid in thinking about doses or protocols. One should think about impairment, one should think about the living situation of the young person, and one should nest one's treatment. I've got my problem about the chat blocking my slide advance. Let's get in quickly. So the point of the book, wrapping up, is to help people manage things like ideas about licenses, manage rules set by formularies, if they are to be thought of as rules, to use the language that prescribers use and distinguish between brand names and generic terms, so they can actually engage with prescribers and promote with them the optimal medical treatment. That means prescribing medicines here. I don't know what SADHD is. That's an intrusion which I didn't pick up. So thank you very much. So I'm going to stop there and deal with questions, if I may.
Gosh, Peter, that was fascinating. We've got a lot of questions, but I'm going to start off with just one quick one. So one of the things you mentioned was whether the medication had the required effect. And does that mainly focus on looking on improving concentration? What are the sort of symptoms that you think the medication will address? So what do parents look out for?
Well, I think, again, this comes back to context. The child I saw on last Thursday, was it Wednesday, whatever, last week, the main problem was hyperactivity. This is an enormously hyperactive 9-year-old who was restless and impulsive and doing silly things far too frequently and getting in trouble within his family and getting into trouble at school. So although he did have inattentive problems, the problem for him was staying out of trouble, and the problem for the parents was managing him, and the problem for the school was containing him in a classroom. So in that sense, we agreed, and I think this is an important thing, that parents should agree with the prescriber what the target is. Because if that can be specified, and in language that the young person at whatever age can understand, then the whole thing falls into place. And I think, my general observation and belief is that if you can find a way of describing what you're trying to do to the young person in the language they can cope with, then they will go along with the medicine. Whereas if it's an imposition, then they won't. So it might be attention and concentration and focus on tasks. And that's tasks are things that are set by other people. An Xbox is not really a task, it's a recreation, but homework is a task. So I think it very much depends on what the target is. And I think the prescriber ought to agree with the parents what the target should be. And that is a dialogue. That's not the parents saying, well, we just don't want any more broken windows sort of thing. And it's not the prescriber saying, well, what you've got to think about is whatever they think is most important. Language, for example. I think it is a dialogue, or ought to be a dialogue, and an agreement on what the medicine is going to do and how to measure it. I haven't, in this talk, talked about the measurement of improvement, but there's a chunk of the book that says you ought to do it in terms that are easily understandable to the young person who's taking the medicine. So it often means a visual chart of some sort.
Okay, that's very helpful. Just one additional question following your comment about the patient you were talking about. So to what extent would you consider sensory integration issues affecting their behavior and their actions?
Well, quite extensively, and they're usually under-recognized. Yes. Particularly in a school environment. We've seen this post-lockdown with a number of children I see going back into schools are saying, I now realise that I can't tolerate schools. I can't stand the smell. I can't stand the noise in the corridors. I can't stand the fan in the laptop that the teacher is using. I hear all those stories. So it becomes important. I think that's more ASD than ADHD, or it may be nothing to do with either. But it's under-recognised. It's a great shame that DSM...
There's research that about 40% of children with ADHD do have major sensory issues. So, yeah. Okay, well, listen, let's... I was just wanted to follow up on that because I think it came out of your talk. So Helen did ask a question to ask how easy is it to adjust the dose for prescribers? And I assume, I don't know if she's referring to it from a regulatory point of view or the guidance from NICE, and whether it's just totally their discretion, and probably how they decide how to decide on adjusting the dose.
Well, I think if you know what you're going to treat, what the problem is, and if you can quantify it, how many times this week have you been in trouble, I would say, to a 10-year-old? This is usually a question that 10-year-olds can't answer, but how many times this week have you been picked up for calling out in class without putting your hand up? And they go, oh, I don't know. And I say, okay, what about yesterday? Or last day you were in school? Were you in trouble? Were you in trouble for calling out without putting your hand up? So if we can get a count on that, if that is something that happens every day, then we know it's happening at least 7 times a week. And if we want to make that child more in tune with their teacher in that instance, you've got something you can count and something you can measure. And adjusting a dose is not difficult. And you can, I think with ADHD medicines, it's pretty straightforward, actually. I mean, for most of them, you've got at least 7 steps of dosage, often more. I mean, the sort of dose range I'm used to with methylphenidate will go literally from 5 milligrams a day up to, for some of mine, 120 milligrams a day. You know, the huge range. So I don't think adjusting a dose is difficult at all.
Okay, actually, Helen has just clarified her original question. She was talking about the bioidentical ones. So if you have a child on, the one type, and the doctor then wants to, or the pediatrician wants to prescribe a bioidentical one, is it just a question of adjusting the dose, or is it just that it works in a totally different way?
No, it's pretty well adjusting the dose. But I mean, a much more sensible arrangement is to prescribe by brand. The NHS don't like that very much. And when my local GP prescribes by brand, they give her a hard time and they make her go and report to Hounslow Health, and she has to waste half a day explaining why she did it. She gets bullied, in short. This isn't actually about ADHD medicines, but I think the key, the pharmacists, in my experience, are quite sensitive to this once they realise the problem. And you don't have to argue about bioequivalence. You just say, look, this manufacturer, their medicines work very well for my child. His ADHD is stabilised on this manufacturer at that dose. Can we make sure we always get it from the same wholesaler? They will actually respond to that.
Okay. That's very, very helpful. Next question is somebody saying that their son is taking Medicanet XL 30 milligrams since May 21, so just the last few months, and it's working well for him. Could he stay on medicine for unlimited period of time, or does he need to stop at some point and then restart again? And if so, for how long is the break?
Well, I think there are 3 bits to, there's a whole book on that, crikey. Another book. The most obvious side effect, I think, of long-term stimulant medication is positive. that the academic gains improve year on year, that the growth of the brain's cerebral cortex increases and normalizes year on year, as it were, if you're talking about a period of years. So if you're talking about prescribing for a number of years, I wouldn't be bothered about side effects unless it's very high dose. There are several American studies about long-term stimulant medication. Some show that a few children on high doses, I don't know what a high dose is, but let us say more than 60 milligrams of methylphenidate every day for more than 7 years, sort of thing, then a few of those children will show some suppression of growth rate. None of them drop below average in that study. And that's probably because a lot of people in that study were very big and very tall to begin with, which is an odd thing. So I'm not worried about long-term medicines in specific terms. In very general terms, I don't want to give medicines if they're not being useful. So I'm keen on stopping medicines every year to find out whether they're useful. Now, in most families, that happens in any case because somebody forgets or the prescription isn't renewed or something like that. So you find out whether it's useful. But a proportion, thank goodness, of young people with ADHD will grow out of their ADHD. We can argue about what proportion, but some will. So I think you need to stop the meds pretty well every year, or find out what happens when you don't take them, to know whether it's doing any good. So I think that several ways of trying to answer that.
I assume the best time to do it would be in the summer holidays when they're not the pressures of school and so on, and you've got a reasonable run at it.
Yeah, I know some families who would say, God, this is when we really need it. But
exactly. And Peter, if you stop it, how long does it take for the body to absorb it, to start working again?
It depends what you're talking about. If you're talking about something like Strattera, I think for some children, it'll be pretty evident within 48 hours. But there are a number where actually the positive effect continues for a remarkably long time, 3 months or so, which is a curious phenomenon I don't think anyone understands, so it's been well demonstrated. So it depends on the medicine. If it's stimulants, you can stop them in any case, bang, like that at any point, and you'll see the result the next day. If it's guanfacine, well, you usually taper off guanfacine rather than stop it. Well, you're supposed to. Then I think you probably need to wait 4 weeks to see what happens. Sorry, have I answered it?
Yes, I think so. Just one final question. Does the body become immune to medicine with time? Is another question we've had.
Not much. Sorry, I've got a disco boat going past outside my window. That's all right. Enjoy if you can hear it. You probably can't. Probably don't. Does it become immune? Well, when you start a medicine, what often happens is it works quite well once you got to a reasonable dose. And then 4, 6, 8 weeks later, it's not working quite as well. Now, there may be 2 reasons for that. One is that what you saw in the first instance as a prescriber was a placebo effect. And the placebo effect is high in ADHD medicines. There's a lot of it about, and it probably accounts for 30% of the improvement initially. So you may just see everyone's enthusiasm for the medicine affecting their judgment, and then that wears off. So it could be a placebo response. But it could also be that the enzymes, the things in their liver that destroy medicines, and because that's what the liver does. The liver destroys 90% of most medicines that are swallowed by mouth. That's what livers are there for, to break down complex molecules. The liver gets better at it. The enzymes are, in technical terms, induced. So that what happens is that you start putting in, well, let's say, I don't know, Lisdex, which is metabolized, broken down by a liver enzyme called CYP2D6, I'm showing off. And that enzyme will increase if it realizes there's more lisdexamphetamine around that's got to be dealt with. It will actually increase. So you may well see over a period of weeks that medicine is less effective because it's being destroyed by the liver before it can get into the general circulation and into the brain. So yes, the answer is you can, I wouldn't use the word immune, but you can need a higher dose than you started off with. And that may be physiological or it may be a placebo effect.
Thank you. So Jolene's asking about the iron and or ferritin that you were referring to. What sort of dose of iron or ferritin have been shown to help with symptoms?
Well, you want to keep your ferritin above 30 if you're doing blood tests. I mean, I don't do blood tests. I used to. I just thought this is a form of torture. Why not get on with it? I think using ordinary iron medicines that you use for anemia, for example, is a bit cruel because they often make children feel sick and produce abdominal pain and constipation and all that sort of thing. But if you use one of the iron-rich tonics that you see advertised on the backs of buses, you can actually get the ferritin up really quite quickly and humanely. So I would just say, well, go and get one of those, I can't remember the names, something ending in Dix or something like that. You use an iron-rich tonic that's approved for children or designed for children. I wouldn't start putting ferrous sulfate tablets into people. I think it can go wrong. The effect is, I reckon, quite small if it's there at all. I can't really make it work. But then on the other hand, you know, I see a biased group of people. They are pretty well, they're well fed. You know, I see people on very reasonable diets. So they're probably getting enough iron in any case. If I was back working in the South London that I knew in the 1970s, where I was seeing children who weren't being properly fed for a whole variety of reasons, then I would think about iron supplementation, but at the moment I don't.
That's helpful. Right, Cindy's asked, she said, what would you recommend as next steps for a 16-year-old boy with ADHD inattentive type who has elevated heart rate, pulse around 130, and he's on both metafenidate and lisdexamphetamine. He also has sensory processing issues.
It's unusual for people to be on both methylphenidate and Lisdex. I see Lisdex, and then as it wears off in the afternoon, put in a short-acting methylphenidate. That could happen. It's not as pharmacologically as elegant as using short-acting dexamphetamine, but I would, if he needs that sort of dose, it is actually quite an unusual combination. But if he needs that sort of dose, then I would, I do three things. I do an ECG, which is pretty straightforward. I just want to make sure that his rapid heart rate is a normal rapid heart rate rather than a rhythm disturbance. I do an ECG. If it's at all funny, I'd get a pediatric cardiologist to have a look, but whenever I do, they always say, well, you know more than I do, get on with it. And if I was worried about that high heart rate, then I'd probably use a beta blocker to slow it a bit. That won't affect the ADHD, but it will calm the heart down a bit.
Good. Okay, thank you. Right, Ulga's asked a question about parents justifying or deciding when to start a child on medication. And then how do you communicate that to a child of 9?
Well, I think I would probably, in real life, I would probably say, look, there are one or 2 points I want to make. I would say, firstly, that national guidance, which means nice, national guidance is take ADHD very seriously. And if the child's development or quality of life is being impaired, then one really ought to use medicines. I mean, the NICE 2018 guidelines are now much more forthright about let's get into medicines quickly. Now, not everyone will agree with that as parents, but the national guidance is let's get realistic about medicines being an effective and safe treatment, etc. I think that the other thing I would say is that you have to imagine what your child is going to say in a few years' time. And I see this quite frequently. I saw it actually within the last 3 weeks. A 16-year-old girl, I was asked to see a 16-year-old girl who had some difficulties managing academic work in school. She had a high measured intelligence. Everybody knew she was bright. That was immediately obvious, but she couldn't somehow get the work done. And part of that was inattention, and part of that was a higher order language problem, which I won't bore everyone with. And I said, look, I really think you ought to carry out a single dose trial or two of methylphenidate. Give a low dose, and I give you instructions for this, like 5 milligrams, one morning at home with you as parents watching, and you give her a 5 milligram dose, and then 60 minutes later, you set a task for her. And there's nearly always homework that has to be done. And you look at the result, and then you repeat the exercise another day, not necessarily the next day, with a 10 milligram dose. And for a 16-year-old, I'd say, well, actually, another day again in the morning, I give her a 15 milligram dose, and you look at the result. And this is an investigation. It's not starting treatment. It's a way of finding out whether this stuff is likely to be useful. Now, in this case, she came back and said, it's magic. I can think, I can write, I can speak. Why the hell didn't you do this for me 10 years ago? I've gone through more than 10 years of school, and it's been agony. Now, why didn't you get this sorted? And she was angry. And I've seen that quite a bit. And that's the sort of story I will tell parents, because it's true that some people will say, why didn't you get this sorted earlier? And I think the last thing is to repeat what I've said already, which is if you can show the young person visually or in terms of numbers what the problem is and what the medicine will do to improve their life or their achievements, then they'll go along with it. And I think that those 3 principles are the thing I hang on to. People will always say, this stuff surely isn't safe. I read in the newspaper, etc., etc. And I then nowadays have to say, well, look, there's a book in the waiting room you can have a look at. So if that's an answer, I think it's quite a complicated issue. Written a chapter on it.
Fabulous. No, that's very, very helpful. Jill commented, and she was very interested in your comment earlier about the difference between American ADHD versus Europe. Can you say a bit more about and what you mean about the differences?
The Centre for Disease Prevention and Control, I don't think I got its title quite right, the national centre that looks at the nation's health in the United States, estimates that 11% of American school children will have ADHD, 11%. Now, I think most people would find that quite a high figure. When you look at the scores on something like the ADHD rating scale, which is one of those things like the Conners, so it counts symptoms. The ADHD rating scale is a bit more straightforward, simple-minded than the Conners, which is why I like it, because I can produce a score on that. Now, the score on the ADHD rating scale that the Americans regard as the threshold for ADHD is 28. The most children in NHS ADHD clinics in this country will be scoring over 40. So the American children are much milder. Their recognition of ADHD, because ADHD is a dimensional concept, it's a spectrum, The Americans recognize it at a much lower level of symptom count. And you have to combine that with all sorts of other things, like the Americans, roughly speaking, are much, like medicines. They're keen on medicines compared with the Brits. But that sort of quantification, those sort of numbers illustrated, the top score on the ADHD rating scale is 54. And by American standards, that is called severe or very severe. But, that's a long way. I don't see children brought in with scores of 28. I mean, that really is quite mild.
Thank you. That's very helpful. Karen has asked about what research has been done on the effect of hormones on teenage girls on ADHD medication.
Sort of none. There are studies on adult women, amphetamines and estrogen, but they are questioned. They're lab type studies. Everybody knows that teenage girls may get a more intense representation of their ADHD premenstrually. That's pretty, it's not universal, but it's well recognized. And most people, I think, who are coming up against that problem, in certainly middle teenagers and upwards, will adjust the dose for a problematic week accordingly, just put it up and then bring it down again, as far as stimulants are concerned. But the actual research on hormones, ADHD and medicines, that sort of triangle, isn't there.
Interesting. Okay, thank you. We've had a further question. You talked about the fact that there's a lack of guidance on combining medication, under the NICE guidelines. Does this mean that, your normal GP just won't prescribe combination medication?
Yes, it does. Yes, it does. They need persuading. They will often say, look, this isn't recognised. Well, I mean, it isn't, because nobody's asked for it to be recognised. NICE is so hung up on drug trials. And drug trials, as I commented, are nearly always about one drug. And that's because nearly all the drug trials, I think all of them actually in recent years, have been carried out by manufacturers. And the NHS and the universities don't do drug trials. You can't get funding for drug trials on ADHD. The drug companies do it themselves because they need to carry out these studies to get their marketing authorization, their license. And then everyone grumbles about the companies and the way they dominate prescribing practice. But actually, nobody else is doing it because you can't get funding for it. So I'm rambling, aren't I? I forgot, what's the focus? Oh, combinations and GPs. Well, I mean, some GPs will, if you explain the point of it to them, they get the point and will go ahead. I mean, it helps if you've got a high university position and you've been doing it for 43 years and you can say all those things. But I mean, in general terms, I think if you explain the logic, they will get it. But generally speaking, most general practitioners' knowledge of ADHD medicines is very, very small.
Yeah, so you may be better off going to see a specialist pediatrician if you being prescribed by your GP and not getting much further.
Well, the GP won't initiate the prescription. GPs are told quite firmly, don't start ADHD medicines. ADHD medicine should be started by a children's doctor with specialist training. The GPs can ignore that, but in practice they don't. So basically, somewhere along the line, a trained and experienced person will have started it, and then. Well, I can go on, but that should be okay. And I don't think one should start with combinations. I think one should always adopt a stepwise approach. You start with the simplest and then you add things in, if appropriate, or you substitute if appropriate, but it should be stepwise and it should be agreed, and it should ideally be run on the basis of a symptom or problem that you can count or measure.
I think that leads us into the next question, which Jolene says, do you have a preference for the order you prescribe medicines that differs to the NICE guidelines?
Well, I think NICE have got the order. Oh, God. No, they haven't. They haven't got it right. In the old days, and you can tell that I'm approaching retirement when I start to use phrases like that, but in the old days, what you did was you made a diagnosis of ADHD and you sat and thought, I wonder whether this person needs stimulant medication like methylphenidate or lisdexamphetamine, or do they need a non-stimulant, a Strattera or an Intuniv? And there are some instances where you would go for a non-stimulant if the problems were mainly in the mornings and evenings for the family rather than predominantly at school, then you'd probably go for a non-stimulant. So in the old days, I mean, that would be a tricyclic antidepressant or Strattera. And if you had somebody who was using recreational drugs unwisely, again, you probably wouldn't jump in with a stimulant. You would start with Strattera. If you got somebody who was showing signs of an early eating disorder, you'd probably go for a non-stimulant rather than methylphenidate or another, or Lisdex as an appetite suppressant. So you'd think about it. That, I think, is still the best approach. Stop and think. But generally speaking, for most people, methylphenidate is a good starting point.
Good, thank you. We've got a question from Amy. She's got a 13-year-old inattentive ADHD daughter, and her daughter is on Equism, and her daughter maintains she doesn't need as much medication as she had in the past. So she was previously on 20 milligrams of Equism, and she's now down to 10 milligrams. What are your thoughts about, reducing doses up or down like that?
Well, I think one should, because again, it's back to this idea of context. What is she up against? I mean, she may be quite right that a higher dose of a long-acting methylphenidate makes her feel socially inhibited and socially awkward. This is a very common complaint by teenagers, that the Medicanets and the Concertas, Medicanet XL, Concerta XL, Equisym XL, make them feel a bit non-spontaneous, a bit inhibited when they're around their mates. They feel as though they've lost their verve and vivacity. Nobody else notices it, but it's quite a strong subjective feeling and really very unpleasant. So she may have worked out for herself that a lower dose is more comfortable socially, and that's important. Young women need their friends for all sorts of reasons, particularly emotional stability. So she may be correct. It may also be a post-lockdown effect, which is the sort of thing that I'm currently juggling with so many people. The dose they were on in lockdown is not the dose they need when they're back at full-time face-to-face school, sort of thing.
And I think that's because school is more demanding, being in a busy environment of school.
Sorry, I missed the first bit.
Sorry, I just you said the doses may often be different, and is that because you think school is more demanding for kids, to get out in a busy environment of school, so they may need a higher doses? Is that what you're suggesting?
That is, yeah. I should think that's the most frequent issue. Though with the boys, the older teenage boys, I think sometimes what one's up against is impulsive, dangerous, if you like, behavior after school. That's when they get into trouble. The peak time of, one instance is the peak time on the clock for shoplifting is 4 o'clock. That's when the kids the late teenagers are out of school. They're on their way home. They're drifting around in groups, and that's when they need to think about impulse control, and medicine may come into that.
Interesting. Yes, I can see that. Now we have got another 10 questions or so, and I'm very conscious it's 9:30. So I think we probably need to just skip through a few of them. There was a question from Sophie, but it's quite complex because it's quite a complex situation. And I wonder if we should just skip over it, because I think it's very bespoke and probably won't apply to a lot of people. If we go on to the next one, it's from Kirsten, who said, how do you typically treat children who experience a rebound effect when the medication or the medicines wear off? Which I know we've just briefly talked about that, but what are your thoughts in terms of how parents deal with that?
This is rebound after taking an immediate release medication or one of the...
I think it's when the medicines wear off, so it's probably a slow release and then the medicines wear off.
Well, rebound after an immediate release, a standard methylphenidate tablet, standard Ritalin, standard Trinculin, standard Medicanet is not rare. It's not common, but it's well recognized. And the short answer there, if that is the case, is move, if you can, to an extended release formulation. And for a primary school person, that'll usually be Equisim XL or Medicanet XL. For a secondary, it'll be one of the Oros group that I've mentioned, half a dozen Concerta XL lookalikes. Now, you can get a rebound after a Concerta XL or lookalike. And if you do, then I would ordinarily put in Intuniv alongside. That's what I would do. I know that within Kingston and Richmond, that is difficult. It can be done. I've got one case where it has now been recognized as a good idea. One local child. An alternative is to use a beta blocker, to use ordinary propranolol, which will block the more unpleasant aspects of the rebound. So you give that, as the child comes back from school, as it were. But I mean, it's usually possible to fiddle around and avoid rebounds. They're moderately common problem, but they're not inevitable. So I would normally go for a longer acting. I would, if that doesn't help, I would add in Intuniv, and if that's impossible, I would put in propranolol as a simple short-acting, reasonably short-acting beta blocker in the afternoon to block it.
Okay, thank you. This is from Kirsten asking, have you seen cases where increasing the dosage comes with an opposite effect of more hyperactivity and aggression?
Yes, and that usually means that something hasn't been picked up. It often means that there's an associated autism spectrum condition, because kids with an ASC don't tolerate stimulant medication very well. So that the stimulant may be effective at low doses, but when you move the dose up, that actually irritates the young person. So that is, looking for something else is quite important. And actually, if I may just loop back to the previous, I'm having an interesting correspondence with a New York psychiatrist who says that when you get a rebound after methylphenidate in the afternoon or evening, you should have another think about whether there's coexisting emotional disorder. And he's got a little bit of evidence from his own work that a coexisting anxiety or low mood can underpin that rebound. I'm not entirely persuaded, and it's an ongoing correspondence, but I just sort of throw that in. It's a good idea to have people say, think harder.
Thank you. We've got an interesting question of somebody who's been to a private psychiatrist and who's written a prescription. And she's asking how long is it before they can transfer the care to their GP to write the prescription instead of the private prescription. And you know, maybe you can explain. I know this is a well-trodden path for you, Peter, because I know you often advise patients on this, but what is your advice? Maybe you can share that with others.
Well, the folk on your patch, sorry, the GPs on your patch, quite often say, we won't do it. I think if you're going to go and see someone privately for the treatment of ADHD, the most important thing to do is to make sure that you get a GP letter of referral. If the GP has referred the case and the opinion comes back, start them on such and such pills, then the GP has made the referral, is really duty bound to accept the recommendation. So a GP letter is actually very important. It's an irritant for many people who think, well, if you're going privately, you ought to just rock up. But I won't see people without a GP letter for that reason. The problem arises over local formularies usually. You know, this is not in our local formulary. And I say, fine, give me the name of the chairman or the medical advisor to the medical formulary, I will write to them. Would that help you? And sometimes they say yes, and sometimes they say, you know, may the force be with you. You know, it won't work. But I find it difficult to know what the answer is. For many GPs, what they want, if it's an ADHD medicine, is a shared care protocol, which spells out what the GP will do and what the consultant will do, specialist will do. And many GPs that I deal with won't really sign up to a shared care protocol until the dose is stabilized. So I've just had this with a family who wants their child to go on Intuniv. And I say, well, look, you can't do this. I can't write to a GP and say, look, this is the escalation of doses. These are the checks that you need to apply. Because I know the GP will come back saying, well, you know, that's your job. Once you know what dose suits him, then I'll take over the prescription. But very difficult for this particular parent to see that. They just think the GP should prescribe. And the GPs won't just do that because they are responsible for what they prescribe. The person who signs the prescription carries the responsibility. So if something went wrong, I mean, it won't, but if something went wrong, then it would be their problem. That's what they're concerned about. So I don't think there's a short answer about how long, but once somebody's been on a fixed and stable and optimal dose for 3 months, I would have thought most GPs would sign up to a shared care protocol and then carry on prescribing. Some will do it more quickly, but I think that's the safest answer I can give.
Good. Well, I think we have probably touched on most questions. There were some that were sort of covered very similar topics, but I think we've had a tremendous seminar, hugely interesting and lots for us to take away and think about. And your book sounds absolutely fascinating, and well, no doubt it'll have a wealth of information, you know, built up over your years of experience. So I would like to really thank you, Peter, for being so generous with your time and, you know, sharing all of this knowledge with us. We've really enjoyed it, and thanks so much to everybody who participated this evening. So good night and have a good evening.
Thank you. On the back of the book, you can't see it, on the back of the book, there's a note by Val Ivans saying this book's all right. So it has local approval.
Val Ivans is our family support lead, so excellent endorsement, and Val's very experienced, so and she works with so many of our local families, so great endorsement. Thanks for mentioning that, Peter. Anyway, good night, everybody. Thanks so much. Bye-bye.